Everyone, to the February 22nd, 2021 COVID-19 clinical care rounds focused on EMS patient care and operations. I'm John Kramer. I'm an emergency physician and EMS physician, the director of the Office of EMS, the National Highway Traffic Safety Administration, and am the team lead for the COVID-19 EMS pre-hospital team. I'm also the EMS medical director for Caroline County, Maryland Department of Emergency Services. The purpose of these sessions is peer-to-peer real-time sharing of COVID-19 EMS challenges and successes. In developing these sessions, our guiding principle is, if I'm preparing my EMS system for COVID-19 patients, the clinicians I want to learn from are those who have the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations who have collaborated in this series. It's not intended to be redundant or replace any organization's initiatives. It is intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Struminger, Amanda, Amy, Celine, Max, Samantha, and the rest of the team for the peer-to-peer learning platform that we're using for these rounds. Upcoming COVID-19 upcoming ECHO clinical COVID-19 rounds currently are typically all US noon Eastern time. Tuesday focuses on critical care rounds, Thursday on emergency department rounds, and we have an ongoing special series on outpatient therapeutics on Wednesdays at noon. It's self-evident that our national medical response challenges are changing every day. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds, we continue to have participants from many states and multiple countries, predominantly physicians, nurses, and EMS clinicians. Special appreciation to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. We continue to receive many questions for each of these rounds and apologize in advance that we're not able to answer all of those. But we do select major themes from the questions received, and we'll be covering them during this or subsequent sessions. We'll also be doing crowdsourcing and polling questions with results shown in real time so that we have the opportunity to learn together. I'll now turn it over to Amanda Dazan to review some of the logistics. Amanda.
Great, thanks. So just a couple quick logistic things to go over. Please use the Q&A function down at the bottom of your screen on Zoom for any questions or comments regarding the presentations and discussion. Please use the chat for questions regarding technical or logistic issues, and we'll also be using the chat for the crowdsourcing question in just a minute. The session today is being recorded and your attendance is consent to be recorded, so thank you. Presentations will be available on our website along with the recording within the next few days. We also offer CME and CE credits for today's session. The link for that is available in the announcement that went out from Project ECHO this morning and will also be put into the chat towards the end of today's session. A quick reminder to everyone that these sessions are focused on improving patient care and health systems and supporting clinicians. So we appreciate everybody keeping things non-political and non-commercial. Quick note on data use, our full policy is here on the screen, but we just want to let you know that while we do collect some data from various things like registration, polls, chat, and all of that, we do keep it all confidential and individual data is not shared. As mentioned earlier, NETEC does have a webinar series that complements these sessions. So the next one will be on Wednesday, and you can go to the NETEC website to view past ones or see other sessions that'll be coming up. Another quick reminder that the AAMC has a continually updated COVID-19 clinical guidance repository. It's available via the link at the top here, and I think we can put it in the chat for you. And back to you for the crowdsourcing question.
Thanks, Amanda. As folks are aware, the session today will be focusing on some of the viral variants that we're starting to see internationally and in the United States. So in looking at this crowdsourcing question, what is the most significant issue or question that your organization currently has regarding COVID-19 virus variants? And when you're responding, if you can, please indicate the country from which you're responding, if outside the United States, or the area of the United States in which you are clinically located. It is now my pleasure to introduce Dr. Jonathan Ju, a professor of emergency medicine at Oregon Health and Sciences University. Dr. Ju is the EMS medical director for Monmouth County, Oregon, which includes the city of Portland and Gresham. He's board certified in emergency medicine, EMS, internal medicine, and infectious diseases, and serves as a site investigator for the CDC Emerging Infectious Disease Network. We couldn't have somebody more qualified to help digest the science associated with these COVID variants and to help us understand them. John, thank you so much for joining us today.
Thank you, John. Can you hear me okay? We're just checking the audio.
We can.
All right. So I'd like to sort of take the introductory comments and give the audience a brief of what we're going to probably be talking about. I'm going to share some about 15 very easy slides to look at here as well. So let me know when you can see it. And now here. Can you see the slides?
We saw the format mode. We're not seeing the presentation mode.
All right.
There
how about
we
now?
go.
Okay.
Yep.
Little glitch here. So we're going to be probably talking about the variants, and I don't expect the audience to see this. There's a lot of letters here, but I'd like to give an idea of the primary principal variants that we're actually interested in. I'll use the acronyms. There is a acronym which is the UK, the site of the original discovery of the variant, as well as the genomic lineage of the variants, as well as the alphabet soup of the mutations. And you can sort of see this and digest it later on. But we're going to be talking about three primary variants that has brought to the attention of the world with SARS-CoV variant. The first one I want to say is that, as everybody here knows, the SARS-CoV virus, COVID-2 virus, is an RNA virus. Inherently with the RNA virus, I'm going to use some acronyms. Some of them are very stable from a genetic genome point of view, and some of them are very sloppy in reassembling. And the sloppiest one I would have to say, using the terms, would be an influenza variant, which changes almost on a monthly basis here as well. SARS-CoV-2 is sort of in between. On a scale of 1 to 10 is about a 5, with measles being about a 1 here as well. So these are two slides from the CDC website as of yesterday, which are tracking three variants. One of them is the B117, otherwise known as the UK Kent variant. The other one is the B1351, which is otherwise known as the South African variant. And the third one is the P1, which is otherwise known as the Brazil variant here as well. As you can sort of see on the map, the B117 has been found ubiquitous almost in the United States here as well. with the highest concentration in 3 states. One of them is obviously Florida, California, and Michigan here as well. The second one, actually, let's look at the B117 as far as virology. Again, I don't expect the audience to know this, but the primary interest is the mutations in the spike proteins as well. And then you have the other portions of the genomes, but I think the spike protein mutations are the ones we are inherently most interested in, because that leads to resistance to our vaccines as well as our therapies here as well. This is it's a cartoon diagram of the SARS-CoV-2 here as well, and you can sort of see the mutations of highest interest here as well. And if you notice, there's a trimer, and there are 3 replicants of the mutations on the primer. The head of the quote unquote, I'm going to call this a broccoli. The head of the broccoli actually sticks onto the cells, and the attachment of the ACE2 receptors, and the tail of the broccoli actually causes the fusion of the SARS-CoV-2 into the cell here as well. And the mutations affect both the head as well as the tail here as well. And this is where the B117 has been found, and essentially it's all over the United States, with the exception of the Rocky Mountain states here as well, maybe because I'm not sure they're testing for it, but that's so be it here as well. So this is the one that's actually worrying because of the exponential rise that the UK variant actually had early on. Let's move on to B1351, which is the South African variant. And personally, I'm the most concerned about the B1351 variant, mainly because of the resistance to the current vaccine therapy we actually have. And I have to be careful how I say this, is that the vaccines, there's still partial efficacy, but not as near as is the amount of efficacy with the B117. You can sort of see the mutations there. There's about 17 to 21 mutations on the B1351 mutations here, and you can sort of see these mutations. The ones I'd actually highlight, the E484K is the one that people are most worried about, which causes the resistance to the antibody that we intrinsically get after a natural infection or the vaccine, and that is the mutation that is the most concern here as well. So where is B1351 located? The answer is it's primarily obviously in South Africa, but it's been spread throughout the world, and it's been found in the United States. If you look at it, it's been found primarily at the eastern seaboard, and then Texas and California have had spotted B1351 variant here as well. Finally, we have the P1 variant here as well, and like many other variants, there's a lot of these things that are out there. I want to highlight that the fact that the variant, although it has different nomenclature, sometimes have the same mutations. So you have to be careful about confusing the mutations from the variant here as well. Here we see that the E484K and the K417T mutations are present in the Brazil variant. This variant actually started, probably was thought to be on its own without any connection to the South African variant, and you can sort of the corresponding lineage of the spike protein here as well. And this is where we're seeing the P1 location in the United States as well as the world, obviously with the source in Brazil. So that basically gives the intro to the variant and what we're expecting here. Back to you, John.
Thanks very much, John. Really appreciate those opening comments, and just a very anecdotal. I remember, I'm not an immunologist, and I defer to you to all of these things, but remember in immunology when we were studying, and all of these things were referred to as stick figures, or were diagrammed as stick figures. Mm-hmm. And to look at those 3D representations now is just unbelievably phenomenal. I think one of the big issues that folks are wrestling with, and this has been reflective in a couple of the comments in the chat. I'll go to those, and then we're going to start going around to members of the panel to chat a little bit. But you had talked about resistance or less effectiveness of the current vaccine to these various variants. Do we have a sense yet whether that decreased effectiveness has to do with infectivity or morbidity or mortality? Like, you know, are folks getting infected easier, more serious disease, things like that?
Yeah, let me be very clear here. First of all, just a disclaimer, I'm not a virologist. It's been a while since I've basically worked with virology here as well. But with that being said, I have some familiarity with virology in my infectious disease fellowship here as well. Number one, we can't classify all the variants in the same bucket. The B.1.1.7 variant is much, is much more infectious. The R about 30 to 70% more infectious. Most authorities think is about 50% more infectious, specifically to the binding protein. In other words, it has a higher affinity to the ACE2 receptors, and it binds much more high affinity. The second one is that the UK initially thought it was just mainly infectious, but the latest data from the UK, and especially in the Kent area, suggests that for certain individuals, it's more virulent. Specifically, the older patients, they have actually documented 20 to 30% increasing mortality in the elderly patients. I have to be careful what I say elderly here, but that's beside the point. In the elderly patients that we actually have here. But regarding the efficacy of the vaccine, it's generally thought that the current vaccine, specifically the Moderna and the Pfizer vaccine, and most likely the AstraZeneca vaccine, are protective against the B.1.1.7. We have not lost too much on the vaccine efficacy. However, so that's number one. So just to highlight, there's increasing infectivity. There's slightly increasing virulence with older individuals, but the vaccine efficacy against the B.1.1.7 is thought to be good with our current vaccines. The second group is the South African and the P1 group, which actually is the group of concern. And that is thought to be more infectious, number one, but also to be much less, the vaccines are much less effective against the B351 to the point that it's a couple of logarithmic. In other words, if you have, assuming that the current 614 variant, which we as in the United States right now is 100%, the South African variant against the vaccine efficacy against the South African variant is around 50%. We're losing a lot of efficacy in that area. Number two, that South Africa has actually documented that people can get reinfected as well. So they have had the original virus and they have gotten reinfected again with the new variant here as well. Number three, and this needs to be, I have to be careful how I say that, there is preliminary work on the AstraZeneca vaccine in showing lack of efficacy on the AstraZeneca vaccine to the point that the South African medical authorities have actually not recommended that vaccine for under the age of 30. I think the young individuals here as well. The P1 variant has not been studied very well, but we can assume that the mutations are the same as a P1351. So that bucket is the same bucket here as well. So again, to reinforce, number one, there is still efficacy, but much less efficacy of the vaccine against the 351 variant. Number two, that the titers of the neutralizing antibody is really important here because you lose 50%. So so your titers that you get from the vaccine are really important because you lose all that safety portion. The titers that you get from the mRNA vaccines are extremely high, especially after the second dose. So you need the high titers for protection against the South African variant. Back to you, John.
Thanks, John. I'd like to turn to the panel now and see if they have follow-up comments or questions. But when you come on, please introduce yourself and then go for it. Dan.
Hi, Doctor. Thank you very much. What an excellent presentation. My name is Dan Gerard. I'm the president-elect for the International Association of EMS Chiefs. And I have two questions for you. The first one, are we seeing, the Johnson & Johnson vaccine is a adenovector vaccine, works a little bit different than the messenger RNA vaccines. Are we seeing, is there any information yet that's available that shows that it has a higher efficacy and higher efficiency in dealing with the variants? And then my second question is specifically about something that you brought up about the South African variant, about the efficacy dropping to 50%. And I'm just wondering, we might see that drop to 50%. Are we seeing a corresponding increase in hospitalizations and deaths? Because when we look at whether we talk about adenovector vaccines or we talk about the messenger RNA vaccines, even if you don't have 100% protection with them, we still don't see hospitalizations and deaths associated with everyone who's received those vaccines. So I'm just wondering, with that South African variant that dropped to 50%, are we seeing an increase in hospitalizations and deaths? And again, thank you very much, sir.
Yeah, I can answer the first question. Number one, the mRNA vaccines have been tested against the South African variant, specifically the Pfizer as well as the Moderna vaccine. These are in vitro, in the lab tests. They have not been tested in the human, at least the control population in human tests. But there's reasons to believe that the in vitro test, the lab test, corresponds to the protection. There are two vaccines that have been tested against the South African vaccine variant. One of them was the AstraZeneca vaccine, as I mentioned. The other one is the Nova virus vaccine, which shows some efficacy against the B1351. I have not seen the Johnson & Johnson vaccine. As everybody here knows, that's a human adenovirus vaccine, very similar, at least conceptually, to the AstraZeneca vaccine. Again, the AstraZeneca vaccine is a chimpanzee vaccine with a spike protein stuck on the outside. The Johnson & Johnson vaccine is a human adenovirus with a spike protein on the outside here as well. So I believe that the Johnson & Johnson vaccine will behave very similarly to the AstraZeneca vaccine. But be very careful here. The Johnson & Johnson vaccine, as everybody here knows, is one shot. No one really knows what happens if you give two shots with the Johnson & Johnson. Does that make sense as well? So, so I think a one shot versus two shot, that's a whole controversy that's going into here. The second question is we believe that you can get sick, but there's still protection of the vaccine against becoming deathly sick or dying. Does that make sense as well? But that's an extrapolation, and I have not seen any human trials yet.
Thank you, sir.
Carol.
Good morning, everybody. I'm Carol Cunningham, the State Medical Director for the Ohio Department of Public Safety Division, EMS. John, thank you for a great presentation. My question is actually related to the fact that our current supply of vaccine, we anticipate that in order to get enough herd immunity, it's going to take possibly to the end of the year. As we prepare, and there may not be data to this, but as we prepare hospitals and EMS services for continued infections, has there been any data on the effectiveness of the current treatment we have against the South African variant in terms of, monoclonal antibodies, remdesivir? One of the biggest challenges was for intubated patients. They were staying on ventilators longer. And I was wondering if there's if we know from those countries, if there's been, even a more prolonged ventilatory requirement. And then lastly, my second question is, and again, there may not be data on this. I was wondering if there's been any difference in the presentation and a level of morbidity of the pediatric population that has been infected by this new strain?
It's a good question, Carol. I can only answer with a guess regarding the monoclonal antibody. The monoclonal antibody against the P1351 is thought to be less efficacious, but still some efficacy against the P1351. You have to be careful here because there are two, at least three genetic mutations. It's the E484 K variant, which actually is stuck on, I'm throwing a little terminology out, but the stem of the spike protein that incorporates it, that prevents the monoclonal antibody from actually working effectively as well. So I believe, and this is my prediction, only not my prediction, that we will have a newer monoclonal antibody. In fact, we're going to have a polyclonal antibody against against the new variant. In fact, I think they're working on that right now. First of all, and very interesting enough, even in the Infectious Disease Society of America, they're lukewarm on the monoclonal antibody for many different reasons here as well. I personally believe right now that it's effective, especially when it's usually anecdotal right now with very limited studies, but I think the combination of polyclonal antibody along with markedly antivirals, as well as some of the cytokine inhibitors that we've seen in the hospital would markedly decrease morbidity and mortality. So I want to be a little bit careful here. If you give, it's the staging of disease. So if everybody here knows, if you have to give the monoclonal antibody, you want to give it in combination therapy. That's number one. Number two, that you have to, the monoclonal antibody is the most efficacious early on in the course of disease before you reach hospitalization here as well. So you want to keep the virus from actually replicating, and you keep the virus from getting you stuck onto the ACE2 inhibitor. So you need to stop that cascade before we actually let the course go on. So as everybody here knows, there's the early form of COVID virus infection in the hospital, and there's a late form, late being the serious illness in ICU. Does that make sense? So first week is the early disease, and the second week is the late disease. And it's in the second week that the cytokine storm has actually set off, and it's like the DIC. Once you set off the cytokine storm, basically the game is over with, and you're basically playing catch up. I'm not sure if I answered your question. The third question is the pediatric question. I don't have enough data on that, but we're starting to see, especially with multi-system inflammatory disease, and even some young people with long haulers as well in the pediatric population, but generally they do much better than the older adults. I'm not sure if I answered your question, Carol, but that's my best shot at it.
No, thank you. I think there'll be more data coming out
Yep.
As this comes out, but we will have that gap where we may have to prepare for surge with ventilators.
Yes,
like that.
absolutely. I think what happened, and the real reason that some of the authorities are worried about the B117 is that the UK experience, remember, they almost were like where we were in around Christmas time. Then all of a sudden they lost it. They went from almost like to the point that their hospitals got overwhelmed, at least in Southeast England.
Yeah. Thank you.
Thank you, John. I just want to remind folks in the audience that if you have particular questions, as some folks have already submitted them, please enter your questions into the chat and we'll pick up on them. Bruce, you had a question?
Yeah, John, thanks. Excellent presentation. I think that really just highlights the urgency of getting the vaccinations out. So a couple of questions kind of related to sift and drift of viruses. So what I'm curious on is there any data or what does the science show? How many variants emerge before we get a completely different disease process? For example, is it 7 variants and then all of a sudden we get a more lethal virus? Or is this, these current variants that are increasing in infectivity and virulence, that's one thing. But again, if where we get a major change in the disease process that makes it a lot more lethal. So what is the end on that is my first question. I would echo again that I hear and I wish that we had more of a national discussion on the antibody therapy. I sat and watched the virus run through one of our nursing homes where the hospitals would not take the patients in. And they sat over there and could have easily had EMS intervene and administer those antibodies, as Medicare is now paying for the antibody therapy to be delivered by paramedics in the field. And we could have intervened over there and probably, maybe been able to knock down a little bit of the deaths. But I echo your comments about the medical community not embracing the antibody therapy in an outpatient setting where it takes about a 2-hour therapy to make it happen. But yet EMS can also deliver that, and Medicare is willing to pay for it.
That's a great question, Bruce, but I can answer the first question sort of circuitously. Number one, if you look at the mutations, the more mutations you have, the more effective the virus is against the human cells. In other words, if you run an in vitro study, if you have one mutations, the current antibody against the serum in people that have been infected is still efficacious. But by the time you have the full panel of all the mutations being anywhere from 17 to 21, you all logarithmically raise the resistance of that virus against the serum of the recovered patients here as well. So number one, there is general correlation between the number of mutations as well as the resistance to the serum of the antibodies that are created against natural or vaccine-related human immunity. Number two, some of the mutations are fairly innocuous, but some of the mutations like the E484K and the B501Y are very basically fundamental. So you need to watch those mutations very closely here as well. So there's 3 mutations that our researchers are watching, specifically attaching to the virus to the cell. And number 2, once it attaches to the cell, there's an incorporation. If you block the antibody from the incorporation portion, the virus gets into the cell and you will create more havoc. Once you get into the cell, the virulence should be more the same, but there is one big problem. Let me actually say the infection. The B117 is thought to have more virus particles. In other words, the inoculation factor, the number of viruses in your nose and your posterior pharynx is much higher with the B117. Does that make sense as well? So logically, it's to assume that if you have more virus, that's bad. And you get worse disease. So it's only postulating that the more virus you have in your system, the worse your clinical course is going to be as well. The third question is the resistance. I'm actually in the minority here. I actually believe in monoclonal or polyclonal therapy. That's the best we got right now. And I actually think that probably does work, but you need much more study. But the one big problem that occurs, so let me slow down here. If you give a monoclonal antibody to a patient who is partially immunocompromised, in other words, someone's on chemo or has CellCep or something like that, that virus has a hard time getting killed by the patient. And it's thought that all the variants that occur are in immunocompromised patients that basically don't have an immune defenses, either humoral or cell-mediated immunity to basically eradicate the virus. And basically what you're breeding is a resistance against that one monoclonal antibody. Am I making sense as well? So here you have to be very careful in the approach of the monoclonal antibody that you're not breeding resistance. There is a hypothesis that that the UK variant came from an immunocompromised patient who was either had cancer or was on cancer chemotherapy and had continuous virus shedding for over 90 days here as well. So there is a basically a problem with the monoclonal antibody in immunocompromised patients.
And just one follow up to that question is, again, is there a specific number in the case history of virology that is it 10 mutations? Is it 12 mutations? Or is that just completely random? And then the last question I have, kind of related to your issue about resistance, is if we are a 1A vaccinator and we're seeing a lot of people miss their second appointments.
Mm-hmm.
And so are we going to develop something like antibiotic resistance by not having people follow up on their second vaccines? And I forgot to identify myself again, Bruce Evans, National Association of EMTs president.
Yes, Bruce. Regarding your question about the number of mutations, it is, first of all, I mean, very careful here. The coronavirus, the SARS-CoV-2, basically is a heterogeneous population. So in other words, it's really sloppy. It basically makes mistakes when it basically replicates itself, and those mistakes are all over the place. There's spontaneous mutations all the time. Usually those spontaneous mutations really will not affect anything, but once in a while you get a mutation, an escape mutation, which is the B117 or the whatever the mutation was, the 501 variant here as well. So when you actually breed a mutation, it's like for us physicians here, we have MRSA. Staph aureus has been known for a period of time, but when you look at the inoculum of Staph aureus, there's many different populations. There's Staph aureus that's methicillin sensitive, and there's Staph aureus that's methicillin resistant. When you give a penicillin, you basically breed a methicillin resistant organism as the predominant organism here as well. So the direct answer to your question is not the number, it is the location of the mutation here as well. Could you repeat the second question, Bruce?
Yeah, I just wondered if people that aren't showing up for their second vaccines, and I know there's been some movement on Pfizer to say it might just be one shot. Are they breeding essentially viral resistance? I think it's a great comment about the immunocompromised people.
Right.
But is somebody who misses a second vaccine potentially going to be ultimately breeding more variants or an antibody or a viral resistance, much like we do with MSRA?
Boy, that's a great question, Bruce. But let me sort of clarify the fog here. As everybody here knows, there is a current controversy whether we should go to the one-shot vaccine and basically wait for the second shot like the UK is doing, or to give the two-shot as prescribed, especially with the Moderna and the Pfizer vaccine. What you really want is the very high titer with antibody. This is what we really do know. Number one, the second shot, as everybody here knows, really basically cements the memory of the B and T cells to the virus. That's number one. Number two, it really markedly increases the titer and the antibody protection against the virus. So you need, and especially with the variants, you need a very high titer. The question that's really a controversy right now is the following. If you actually look at the younger people who are given the vaccine usually do very well with one vaccine. I'm talking about younger, under 50. But if you look at the older you get, the more you need the second shot, because your titers are really poor until you get the second shot here as well. If you have a low enough titer, I'm getting a roundabout answer to Bruce's question, you will breed a resistant organism. Essentially. So what you really want is complete protection against the virus from getting severe disease, as well as preventing the mutant organism from escaping your immunocompromise. And you need a high titer, as well as a very aware cellular immunity to raise that question here as well. And for that question is that CDC actually suggests that up to 6 weeks after the first shot is acceptable according to the CDC website as of a week ago here as well. But we want to make sure that everybody should get their second shot roughly as close to the schedule as you can. I'm a two-shot kind of person right now, but with one caveat. If you had to delay it, I would not delay the older patients, and I would delay the younger patients. That's number one. Number two, that the people who had the COVID actually do very well with one shot. So we have a whole group of firefighter EMTs that already had COVID and they're getting immunized, but our data currently right now would suggest that one shot would give you astronomical titers. Back to you, John and Bruce.
Fascinating discussion. Thank you. For the ECHO folks, we'll go to the polling questions here in just a second. I just want to remind folks in the audience, several folks have raised their hand, and with this platform, we don't have the opportunity of having you come on verbally. So if you would make sure that you put your questions into the chat, we will look for them and pay attention to them. Thanks. Amanda or Amy, can we go to the polling questions? All right, and we have 5 today, so it'll be covering a little bit of a spectrum. Which of the following is true regarding COVID-19 for those of you that are EMS clinicians? And folks jumped on this one very, very quickly. We'll go a couple more seconds here. Rick, I think the highest we've ever gotten to is 72% respondents, if I remember correctly.
Yeah, I think that's right, John. You know, we repeated the question probably like, this might be the 6th time on the various different series of rounds. So
yep.
Really difficult to tell who's, you know, participated previously, not participated before, but the trend is in the right direction for sure.
Yep, we're leveling off here. So if you can show us our responses. Almost 2/3 have gotten the first and second dose so far. Very good, thank you. Our next question. EMS clinicians in our region are administering COVID-19 vaccines. Oh, I will tell you that the folks that were voting yes jumped on this one very quickly, and it would have been fun to close off the polling after about 8 seconds. But we're leveling off here, so please show us the results. So we've got half of the systems reporting are participating, a little under 1/3. When we opened up this question and the affirmatives jumped on it, it was up to 75% for a very brief period of time, but we're still doing well. Thank you. Next question. Since January 1st of this year, has your agency seen variations in the clinical presentation? Now, we're not talking about the variants themselves, but variations in the clinical presentation of COVID-19 patients. Very good. We're leveling off here. Let's look at our responses. Unsure, don't know. Yeah, I think that's some, Rick Hunt and I have been talking about this over the last week or 10 days. And I think this is something that both from an emergency department and an EMS side, we're gonna spend a little bit more time starting to look at, see if there are differences in our clinical presentations.
Hey, John,
Next question. Go ahead, Rick.
really quickly on this. I would really encourage people to make sure that they see how John's worded this, not variants. This is about clinical patterns. You know, it could get really garbled very quickly to like try to associate something with something we're not sure about. So whether or not variant related or not variant related, it's the clinical pattern issue, and 26% tracks pretty well with what we've seen over the past, I think, 3 previous rounds with 37% in previous rounds. Thanks, John.
Thank you, Rick. Next question. Since January 1st, again, of this year, the severity of illness in patients, of COVID-19 patients that my agency is seeing is increasing, decreasing, staying the same. Now, this is obviously tied in with the last question. There are some differences here that can be relatively subtle in terms of the severity of illness versus clinical presentation. But again, we're going to continue to pay attention to those moving forward. Okay, we're leveling off here. The results, please. About the same and decreasing, very close to each other, which actually is a good trend to be having. And I think our last question. Since January 1st, the number of COVID-19 patients that our agency is caring for, increasing, decreasing, staying the same. All right, survey says decreasing by about half of the respondents' population. Great, thank you. I believe that's the last question. John, one of the questions that came up in the chat just now has to do, going back to is this going to likely be an annual event? Will folks have to be tested before deciding whether a booster is required? Any thoughts on that?
That's a good question. Most likely, no. No. As everybody here knows, both Moderna and Pfizer are working on a booster shot literally as we speak as well. So I actually think that because we're starting to understand the SARS-CoV-2, this may be like the analogy like our annual flu shot. Does that make sense as well? So I anticipate a booster shot being deployed sometime in the fall or winter when we get another surge as well. Again, the first shot is protective, but you want to be more protective with the booster shot.
Yeah, John, you had mentioned earlier the theoretical consideration that if you had to delay a second dose, those in the younger population or those that have recovered from COVID might be a population in which you'd consider delaying the second dose. Does that apply for the older population who have recovered from COVID? Any idea?
It depends upon recovery, but the answer is that's pure speculation right now. I think it does apply, but the people, as everybody here knows, is the most at risk is the naive. In other words, people who have not had COVID that are older here as well. I think personally they should get 2 shots as well, given what we do know.
Thank you. Any other questions or comments from the panel? Carol.
Yeah, this has been a great presentation. I think it actually emboldens the fact that we need to really encourage our EMS providers as well as emergency care and frontline healthcare workers to get vaccinated. I think sometimes people go into freeze frame when they hear about a new strain and they aren't sure what the new regimen is, but it's better to have partial protection than no protection because the death rates are still continuing. Thank you.
Yeah, Carol, if I could actually add on to that question here. There's been a myth in the public that this vaccine was rushed. You have to be really careful with that statement. We have known about this virus, SARS-CoV-1, for over a decade and a half, at least. Does that make sense as well? So between SARS-CoV-1, otherwise known as Hong Kong SARS, as well as the MERS, there has been basic science research that has been going on for 2 decades. What is new is the mRNA vaccines. That is what's new here as well. But to say that the research is rushed is probably a mistaken misnomer here. What we have done was we have understood the protection against the SARS-CoV virus, and we basically created a vaccine against that SARS-CoV virus as well. There's been a couple chat questions. One of them is, has there been any of the cytokine inhibitors that have benefited the in-hospital, especially severe patients that Carol was talking about? The answer is yes, there is pretty good data on tocilizumab as well, which is a cytokine inhibitor used in rheumatoid arthritis. That in combination with remdesivir and the usual ICU care has led to improve, and Decadron obviously led to improved outcomes here as well. The second question is what EMS effects on the variants will have. The answer is the best answer to that is what UK and the Kent EMS found in the UK. They were basically overwhelmed, very similar to what we saw in LA, where they had a volume of patient that was basically tremendous and overwhelmed the hospitals and the EMS agencies. Back to you, John.
A question that just came up, and I appreciate that. I meant to raise it earlier. Do these variants affect the testing capabilities that we have currently?
No. You have to be careful what we say about testing capabilities. So my answer is the following. If you're testing for the SARS-CoV-2 virus itself, in other words, a nasal or throat swab or spit, that is a PCR test or an antigen test, depending on what kind of test you have, that basically tests for the virus. Your vaccine will not basically affect that test at all, unless there's something really weird. The second one is if you actually draw the antibody test, it will affect the antibody test for obvious reasons here as well. So it depends on what kind of test, but most of the people, when they talk about tests, are talking about the antigen or the PCR test that we're talking about.
Thank you.
Hey, John, I would just say, for those 30 percenters out there, I think between you, Dr. Kramer, and you, Dr. Hunt, I think it's very important that EMS gets in the game to be doing these vaccines and helping assist the public health agencies, which don't necessarily have the heavy lift capability and the muscle to make this happen. And I don't know what it's going to take to get people out of the stations and into the vaccination mode or supplementing the large vaccination centers. I can tell you, as a rural super rural provider. We'll be doing our 1,000th dose to the public tomorrow, and I've only got 12,000 people in my district. If a little podunk like mine can do it, then certainly Danny Gerard's metropolitan area can do it. So I really think that we need a push by all the agencies, all the associations, all the regulators to get EMS in the game on this thing.
Carol, and then
Yeah,
Rick.
if I can tail onto that, yeah, I'm still very proud that during H1N1 in Ohio, the majority of vaccinations in the mass campaign was administered by EMS providers. Oftentimes the hurdle is your state's regulations. We changed that in Ohio back, in 2008. If the training is an issue, please go to the Ohio Department of Public Safety Divisions of EMS website. We have training modules for the Moderna, the Pfizer, the influenza vaccine. Obviously, you only have to tweak it to your scope of practice, but we put it out there for Ohio, but it's free for everybody to use. And I think oftentimes that is probably the second hurdle. But of all times, this is a time where EMS needs to stand shoulder to shoulder with every other healthcare sector and be part of the solution and get out there and vaccinate. I want to emphasize what Bruce has said, probably 200%. The resources are out there. Hopefully we can get those states who don't allow it to step into the light, see the light. If you can give a shot in the field, you can give a shot at an immunization clinic. Thank you.
Thanks, Carol. Very important comment. Yes, there are a number of training resources that are available out there. Ohio, Minnesota, Maryland. We put together some information from FEMA a couple of weeks ago that FEMA has been sharing with their regional offices, available on ems.gov as well. So there was also a question about reimbursement. The vaccines themselves are provided at no cost to the patient, and regardless of who is administering the vaccine, there is no cost to the patient. EMS agencies either working with the CDC recognized vaccination agency in their area or can apply to HHS. There is reimbursement available through several mechanisms for the administration fee only, but the vaccine and the supplies associated with administering the vaccine are covered and are not able to be charged to the patient. We are at the top of the hour, John, as you've noticed in the chat section. Very important discussion. You nailed it. Thank you so much for doing that. Any parting shots? I'm sorry, parting comments from your perspective on the vaccine?
I firmly, I'm into the vaccine camp here. If you have any doubts at all on the efficacy of the vaccines, please restudy that again, because I'm a firm believer, especially with COVID and the vaccines, for those EMS providers that haven't received the vaccine. Having treated COVID patients, you don't want to have COVID at all. Between the long haulers and the fog and even the asymptomatic myocarditis and stuff like that, it's really a bad disease here as well. So think again, because I'm really a vaccine advocate. Number two, that the science is always changing here as well. We learn more as we go along, so we need to be flexible regarding what we do know about it. I do think that the improved vaccines with the booster shots will be available. And I do think that the therapy will be markedly enhanced like we do in the hospital here as well. So I'm cautiously optimistic about that. And number three, be safe and be careful.
Thank you, John. I think it's fair to say that this has helped with the understanding of everybody that's heard you today. I think it's also fair to say, as this continues to evolve, you're going to be back at some time in the future. update us on the activities of where we are at that time. John, thank you so much. Panelists, thank you. Echo team, thank you. Audience, as always, you've been great participants. Thank you all. And we will see you next week on the next EMS series. Stay safe, everybody.